to now introduce Alex Chan, who is going to be our keynote speaker to start us off. He's the Associate Director of the National Strategy at the Clinton Foundation. For the Clinton Health Matters Initiative, and oversees a national portfolio of programs focused on chronic disease prevention and treatment. He manages initiatives that address critical needs or gaps in services across a broad array of domestic health issues, such as increasing the capacity of mental health and substance abuse services on college campuses, expanding access to life-saving opioid reversal agents through negotiated agreements with pharmaceutical manufacturers, and more. Prior to joining the foundation, he worked in both the public and private sectors on projects designed to improve public health outcomes through interventions and changes to the built environment. So please help me in welcoming Alex. Thank you so much.
So good evening, everyone. I hope that everybody is as excited as I am to hear from the panelists and presenters that are on track for the rest of the summit. And before I start, I want to thank the ASID. I want to thank Randy. I want to thank Fernando and the staff for inviting me to come down and talk to you about what I think is a very important topic, and that's really the intersection of health and the built environment, the physical environment, where that intersection lies and what the opportunities for collective impact and collaboration are at that juncture. I don't want to start with a laundry list of why this is important. What I am going to assume with this crowd is that we all know why this is an important and critical issue for us to speak to, and I think if I did start there, I'd be here up all night with an exhaustive list and we'd all be very bored. But what I do want to jump right into is really why we focus on that, why I hope that you are compelled to focus on that issue, and what we can do moving forward as a collective, in the words of Randy, and really looking at how a collective impact model can help shape and guide our efforts individually, in the organizations that we work for, and in the industries that we work for. And so, jumping right into it, really, what we have found, and it's not work that the Clinton Foundation owns, but the University of Wisconsin Population Health Institute publishes what's called the County Health Rankings Model. Part of that model, which ranks the health of counties nationwide on an annual basis, is looking at what are the actual determinants of health for an individual, for a region, for a community. And what they have found is that less than 20% of an individual's health outcomes is actually related to clinical care. Who you go to the doctor, where you go to a hospital, how you receive care, what you receive, that accounts for less than 20% of your individual well-being. Think about that for a second and think as, in your mind, does that jive with the sheer number of dollars that Americans, that the American government, that institutions and employers spend on healthcare? Less than 20% of your health is determined by your access to clinical care. What is that 80%? What's the remainder? And what research has found, and there's a compelling and growing body of evidence, not just at the University of Wisconsin now, but throughout multiple academic research centers, is that other 80% is what we call the social determinants of health. It's income, it's employment, it's education, it's where you live, it's sexual activity, physical activity, nutrition, and it's the physical environment. It's that space that you interact with. It's the infrastructure that changes your body over time, given different inputs and outputs. And that's where I think we as a collective today can all move, in that space of the physical environment and its intersection with health. And what I want to do is really talk about what we can do as a collective and how we can apply a collective impact model to the work that we all would like to do in this space. And really, it's about harnessing our passions and our interest in this space in a way that aligns all of our efforts for a common goal. And I'm going to take a step back, and Randy gave a brief overview of what I've done in this space, and really it's not much. But my passion for building healthier spaces and places really comes from, I don't know where, but as a child, I used to build imaginary cities on this construction mound in my parents' backyard with Legos and whatever toys I could get. And I built and rebuilt and reimagined cities over and over again. That construction mound stayed there. I wouldn't let my parents take it away until I went off to college, and then they got rid of it right away. But that passion and that interest in cities and how spaces interact with land use, with the natural environment has stayed with me, and I've carried that in my professional interest. I spent my first couple of years outside of undergrad working for a multinational consulting firm doing real estate finance, which is very soul-crushing. And it wasn't what I wanted to do. It wasn't we weren't working in the space of social good or social impact. And so then I spent the next 6 to 7 years working in a suburb as a planning manager, overseeing land use planning functions for a suburb in Southern California, which is where I really kind of got knee-deep into this space, and where I was introduced to people in the public health side that were looking at physical interventions in the built environment to reduce chronic diseases and intervene in that space. And that really kind of propelled me to the Clinton Foundation, where for me, and hopefully for you and those that we work with, all those different connected parts related to health in the built environment really came together. So what were once disparate, either issues or factors or outcomes, now really does make sense for me, in the sense that if we use the social determinants of health as the foundation for our work, and we know that all these things are interlinked and interconnected and related in a very meaningful way, we can begin to move and see actual progress in a way that we couldn't before if we were operating in our silos. So what I would like to do is put forth a model for that collective impact action, what that might look like for us, for those in the room. And when I say us, I don't mean just interior designers. I'm hopeful that there's others here from the architectural fields, from urban planning fields, from real estate developers, even those in the furniture making. I talked to a few folks on the bus who have some interesting backgrounds that aren't just specific to interior design. Because all of those have a role to play. And all of those have space in this issue to really make an impact and to change, and to effectuate change. And so what I want to do is talk about collective impact as a model, how we use it at the foundation, really how that translates to even what ASID is doing around the health design protocols, and then really talk about what are some key principles of engagement around collective impact that we use. And again, not as a point of this is a tried and tested model that you have to use, but more so to spark ideas, to see if it resonates with you and your communities and your constituents. And then when you go back into those workshops, either today or tomorrow, to think about what would those principles of engagement around collective impact look for you, or for your community, or for your industry. And so at the Clinton Health Matters Initiative, like Randy said, we focus on the prevention, treatment, and management of chronic diseases across the entire age spectrum, but only domestically at this point. So we are only working in the US, but we're hopeful that as we build and scale programs, we'll be able to take them internationally into other communities. But what we do is we ground our work in the social determinants of health. So we don't, although we certainly partner with health systems and hospital providers, we don't focus our energies in that space, because there's a lot of energy in that space and there's a lot of programs already there. What we do, though, is we look at where there are gaps in services, and really where are there communities of needs, or where are there populations that are suffering disproportionately from poor health outcomes that we can help fill the gap. And that's how we dictate our work, and that's where we move. And I think one of the driving forces behind our work, and certainly the foundation as a whole, is knowing that we can't solve any of these problems by ourselves. There's nothing that the foundation does. Any of the 11 initiatives, it's kind of overwhelming, and I know why you got tripped up there. So there's 11 initiatives under the foundation, and we all work solely in partnerships with others. It's kind of I shouldn't use those terms, but we work in partnerships with others. That's the only way we deliver our services. That's the only way that we operate our programs. And that's really the only way that we start to identify where there's gaps in services that we can add value to. And it really is based on this model that 1 + 1 + 1 + 1 doesn't have to equal 3. If we leverage partnerships with the right resources, with the right skill sets and the right proficiencies, we can make 1 + 1 + 1 = 5, or we can make it equal 10. And that's really the true value in partnering and working within a collective impact model, is that your independent and individual assets are magnified to a place where you couldn't do that on your own. And the foundation is really taking that as its mantra. And I think the more that I learn about what ASID is doing, I see that in different facets of their work as well. And it's encouraging to see other organizations that have that same philosophy and use that in their work. And one of the reasons why I think the foundation and ASID are really primed to lead in this space, and hopefully other organizations like those two entities, is one, ASID is a membership organization. It represents professionals in this industry, and there's multiple viewpoints, there's multiple perspectives that they bring to the table and that they can coalesce around an issue as significant as health and the built environment. The foundation, given our work with cross-sectoral partners, is also, this is ingrained in our DNA, and I think it's ingrained in both organizations' DNA. It's something that the former President Bill Clinton was very intentional about when he set up the foundation. He never meant this to be a vanity project or a project in which our name supersedes everyone else's. It's always our name in line with 10 other people. In some cases, our name isn't even on there because we may not actually be doing the good work. We may be behind the scenes, and that's okay. It's not about recognizing who does the work, it's about the work getting done. And so I want to give a few examples, some concrete examples, again, more so in the frame of sparking ideas and helping people generate ideas of what they might do around collective impact and really looking at health in the built environment. And ASID has a perfect example in their commitment to action with the Clinton Global Initiative. They're developing healthy design protocols for manufacturers, for design professionals like yourselves, and for those in the space to really work with these protocols to design healthy interiors and healthy products. And from what I can tell in a few conversations we've had about it, there's multiple points of engagement, there's multiple points of input and participation for those involved, and it's not ASID, it's a coalition of like-minded folks, including ASID, Lake Nona, Gensler, the NIH, coming together and aligning their efforts to achieve one common goal. And I think that's very admirable, and certainly one in which I'm excited to learn more about and see as it moves forward. I'll give you an example from the foundation. One of the platforms that the Clinton Health Matters initiative operates is a community-based platform. So we operate what's called the Community Health Transformation Project Area in 5 regions nationwide now. We're in Houston, Little Rock, Jacksonville, small rural county in Mississippi, Adams County, and also the Coachella Valley in California. And that's where I want to pull an example from. If you're not familiar with the Coachella Valley, some of you may be if I bring up the city Palm Springs, because that's where Palm Springs is located. And the Coachella Valley is really a region of haves and have-nots. Most people associate it with golf courses, resorts, hotels, high-end residential. And for 4 cities out of 9, that's certainly the case. The other 5 cities in the eastern half of the Coachella Valley are primarily agricultural, low-end residential, high health needs, and a very migrant population due to the heavy agricultural presence there. And so we've been working with this community now for the better part of 3 years. As part of our model, we convene regional stakeholders, bring them together, sit them in a room, very much like what we're doing today, but then map out a blueprint for action. So it's an actionable plan in which they develop actionable items in each of those key social determinants of health, and it's the same across, or the determinants are the same in every community, but the action items are different. And then we commit our resources for a period of 5 years to help facilitate the implementation of those action items. So one of the action items under the built environment for the Coachella Valley was to change the policies of the 9 municipalities to support better health outcomes. And we've done that now, I think, in a hopefully a novel way, and one in which we can scale and replicate it to other communities. But we're working with all 9 communities, both the haves and the have-nots, and we've already identified in their policies, in their land use planning documents, in their administrative policy documents, in their development guidelines, in their architectural guidelines, which also include interior design and architecture, I should say landscape design. We've identified areas in which they're either deficient in terms of promoting health, or where in some cases, surprisingly, they're actually promoting ill health. In some cases, cities have required homes to be 100 feet apart, so you end up with these huge subdivisions where people have to drive from place to place, and really discourages physical activity and a cohesive sense of community. And so we did the initial analysis. We've discussed that with them. We've identified areas where they're comfortable moving, because it's not about us saying, you have to do this, but it's really about us saying, here's a menu of options that we can work with you on, and here's where we think we can get the best traction. But you tell us what needs you want addressed and what you have the capacity to do. And so several cities now have gone to that second phase where they're actually crafting new policies or going through the slow process of revising policies at the city level. And some have even decided to take this on their own and developed whole-scale new plans for health within their city, which we think is fantastic. And again, it's bringing people together, the haves and the have-nots in this community, because there's lessons that both sides can learn from each other. Certainly the cities that were doing things well had lessons that they had learned and tested and piloted that the other communities could learn from. And certainly those that were suffering and had huge need also had opportunities and a real need to share that with other communities, because health doesn't stop at jurisdictional boundaries. It doesn't obey a city line. It doesn't obey a housing tract stop line. It's the scope of the physical environment that we all interact with is so much bigger than our arbitrary limitations on it that we knew that we had to bring all 9 cities together in that case. So I use that, again, as just an example of how different organizations are coming together around the space of health and what that collaboration and that collective impact model can look like. What I do want to talk about now and really spend some time is what are those guiding principles that we use? And I want to share that with you in the hope of getting you all to think about what those principles might look like for you or your communities. And there's 3 primary guiding principles that we use to engage on collective impact. And again, this, and I want to stress this isn't anything that the Clinton Foundation or myself, that we have ownership over. These are concepts and ideas that have been used in countries and nations and communities worldwide for a very long time. But it takes practice and it takes discipline and it takes a commitment to really engage in this collective impact process. And it's very easy to lose sight when you're managing multiple relationships, multiple agendas, multiple partnerships, and competing interests. And so we've found that these 3 principles really ground our work and help us and our partners to continue driving change in a way that is mapped back to our original goals and helps us really achieve the impact that we want. And so the 3 principles are to meet people where they're at, to utilize partnerships of purpose, and I'll expand on that a little bit more. And then lastly, and this is the first 2 really lead into the last one, is to make health the default choice. It's kind of self-explanatory, but in a lot of cases you would think, we found that people forget that to really prompt behavioral change, you need to make it the easiest option. But I'm going to go back to the first one first. So I want to talk about meeting people where they're at. And that, again, I think is also self-explanatory. We use these in the sense that, or for the purpose that we don't have to do a lot of explanation. But I do want to build that out too, and not just say that, remember, meet people where they're at, but also there are a couple key points behind that. One is don't assume. And the other is to use a language that everybody can understand. Because as professionals, I know I certainly fell into this trap when I was working in land use planning and real estate finance. When you're talking to stakeholders and you're using terms that nobody else outside your profession uses, you lose people instantaneously. And that's true in health. I've been on calls where people throw out 30 acronyms in 5 minutes and I'm done. I don't know what they're talking about. I don't know who they're referring to, and I've lost both my desire to participate, but also my ability to. And what I want to use as an example of meeting people where they're at is the usage of health technology and the push to promote new health technology and digital innovation in the space of health. And what research coming out of the University of Texas has found is that the simplest form of technology out there is actually the most effective. Wearables, digital apps, platforms that are web-based, all are great and shiny, but you want to know the one thing that most people communicate with and that is shown to be effective in changing health behaviors is it's texting. And the reason why is that it's almost universally used in the United States across cultural groups, ethnic groups, socioeconomic backgrounds. And most people, there's a very low cost barrier to use to use that technology. Most people have texting. Who do you know that doesn't have texting? And so in the conversations that we have with a lot of folks where they're rushing to put out an app that'll help low-income kids get more active or help them with better nutrition, we try to dial it back and say, like, don't assume that media that you are excited about is actually the right media. Don't assume that technological language that you're using and that you want to apply to the situation is the right space to use it in. So those are just the two principles behind meeting people where they're at. I should say the two key points behind meeting people where at that I want to really expand upon. And then two more with building partnerships of purpose. For us, it's making sure that these partnerships are grounded in data and that they're using measurable results, or at least tracking data and using some system of metrics and evaluation to ensure that as we move along to this aligned and common goal, that we actually have the data to support that. Because sometimes, again, our assumptions might be wrong and we need to course correct, and that's okay. The other part of that in terms of meeting people where they're at is really looking to build partnerships with an eye to scale and replicate. So one-off initiatives are great, but they aren't sustainable. They're not lasting, and they won't be in the community 5 years from now if that's the only outcome or goal that you're hoping to achieve. Really build things with an eye to model and scale and replicate in other communities or with other groups, because that will inform the decisions you make, and that will make the change that you're looking for much more sustainable. And then the last one I really am going to skip over, because making health a default option is something that I think you as designers are all inherently prepared to do. Making it not a choice, but a background noise that doesn't even happen, that people don't even know they're doing, that they don't know that they're either purchasing healthier furniture or that they're renting and buying property that has been designed with better materials or better systems for particulates in the air, pollutants in the environment. And so making health a default option is absolutely critical. But again, I think if you do everything else right, that is the end result. And I know I'm running out of time, so I'm going to end with this. I'm going to prompt you all to watch a video that is widely available. I won't replicate it here. I won't show it. But what it does is it shows one man at a concert festival. Some of you have probably seen this, and it's a perfect example of how to build a movement. One man flailing his arms, dancing wildly, really looking like just out of his mind nuts. But if you look at the video, he's enjoying himself. But everybody kind of is looking off to the side wondering, what is this guy doing? He's dancing like a fool. If you've ever seen Seinfeld, you know the character Elaine, when she's dancing hysterically at a party, this is what that guy is dancing like. And the video is about 3 minutes long. The first minute, it's him dancing by himself in a crowd of several people. After 1 minute, a second person joins him. And now it's not just one person dancing, it's two. And then very shortly after, a third, and then a fourth, and then a fifth. And with each successive person, the time between that person getting up and the next person joining becomes shorter and shorter and shorter, until eventually the entire lawn is up. And that is, without having to describe more, is the perfect analogy for what we attempt to do with movements and collective action. It doesn't matter if you're the first person dancing. It doesn't matter if you're the second, the third, the fourth, the 100th. It just matters that you are, and we all have a part to play. I myself am not the original dancer. I've benefited and been fortunate to work with people who are. But there's a need for people to support that movement. There's a need for people to stand up and say, this matters, we are going to address this, and here's how. And that's what I'll leave you with. I hope you all have a fantastic summit and appreciate your time.